Hi, welcome to Strategies to Increase HPV Vaccination Rates. My name is Rachel Wallace-Brodeur. I'm a project manager and quality improvement coach at the Vermont Child Health Improvement Program. I work for the National Improvement Partnership Network, which is an organization of 20 plus improvement partnerships around the country who have the goal of improving healthcare for children. This webinar or this training was developed for the Washington Department of Health AFIX program. So the agenda in this training, I'll do a short introduction of the National Immunization Partnership with the APA, and then we'll get into some strategies for increasing HPV vaccination. So that includes a strong recommendation for the vaccine, and then some strategies to reduce missed opportunities. And finally, we'll do some stories from the field, lessons that we've learned from our NIPA Learning Collaborative. So I'll just give an introduction of what NIPA is. So NIPA stands for the National Immunization Partnership with the APA, or Academic Pediatric Association. This is a project that's funded by a CDC cooperative agreement, and it's a partnership between the APA and the National Improvement Partnership Network, or NIPIN, where I represent. And as part of this work, we established an HPV Virtual Learning and Improvement Network with the goal of increasing HPV vaccination rates among adolescents ages 11 to 17 years old. So for this project, the APA did a learning collaborative among continuity clinics as part of their CoreNet network, and NIPIN ran a learning collaborative among community practices. So these were run in parallel. They're 9-month learning collaboratives involving multi-states. All the training was virtual. We are currently in our 4th cohort, and we have a 5th planned. And so far, we've trained providers and staff at 233 sites in 22 states. And this map in the lower right-hand corner shows you our sites for our first 3 cohorts. And we've trained providers at pediatric sites, family medicine, adolescent health, community health, public health, as well as specialty clinics. So we've really had a broad reach with this project. And I introduced this project because the materials in this training come from the work in this project, both from our faculty and from our participating practices who are involved in this project. So I'm going to begin with a strong recommendation for HPV vaccine. And I like to begin here because how the provider recommends the HPV vaccine can make all the difference to a family's acceptance. We hear again and again from our participating sites how shocked they are the difference it made in just how they presented the vaccine with parents' acceptance of the vaccine. So just what is a strong provider recommendation? So with a strong provider recommendation, you want to use presumptive language. So just to give you an example of that, we often think of providers using either participatory or presumptive language. So participatory language really provides parents with more decision-making latitude. So offering the vaccine in this manner might be something like, have you thought about whether you'd like your son to get the HPV vaccine? Or often providers offer the HPV vaccine as an add-on. So saying something like, your child is due for the Tdap and meningococcal vaccines today. Would you also like to get the HPV vaccine? Those are more participatory language. Using a presumptive approach presupposes that the parent will get the HPV vaccine. So instead of asking whether they'd like the vaccine, providers state, Cora is due for the HPV vaccine today. So using that presumptive language really lets parents know that it's the norm to get the vaccine, you expect that the child will get the vaccine, and it's really indicating that you believe the vaccine is the best choice. The other component of a strong provider recommendation is really offering the vaccine the same way and the same day as you do the other adolescent vaccines. So group all the adolescent vaccines, recommend HPV vaccination the same way you would recommend Tdap and meningococcal vaccines. So don't separate it out. Don't provide any more information about it than you would for the other vaccines. You really want to present the HPV vaccine as just another vaccine. So really think about it using the same language you do for Tdap and meningococcal vaccines. And then you want to do it the same day. So recommend HPV vaccine on the day that they're getting Tdap and meningococcal. You don't give them those two vaccines and then have them come back for that HPV vaccine. So here's some sample language of a strong provider recommendation. Your child needs 3 vaccines today: Tdap, HPV, and meningococcal. Very straightforward, very easy. Uses that presumptive approach, treats the HPV vaccine just like the other 2 vaccines. Another sample language is, today your child should have 3 vaccines. They're designed to protect him from meningitis, cancers caused by HPV, and tetanus, diphtheria, and pertussis. A little bit more in depth, but again, just treating all 3 vaccines the same way. The other thing you want to think about when you're recommending HPV vaccine, that is illustrated in the second text, is that the focus is on cancer prevention. That's really what this vaccine is about. So what we would recommend for providers who aren't currently giving a strong provider recommendation is really develop a text that works for how you speak to kids about and parents about vaccine, and try it out with some patients and see how that goes. And really play around with the language, find what works for you. We encourage all staff to use this kind of language. So when the person who's rooming the patient is rooming them, they can set the stage saying, you will be receiving 3 vaccines today, same as when they check in at the front desk. So now I'm going to talk about some strategies for reducing missed opportunities for HPV vaccine. And what exactly is a missed opportunity for vaccine? We define it as a child who has a visit to the clinic or practice who is eligible to receive a dose of that HPV vaccine, but they don't receive it. So you can see there's really many reasons or ways that you might have a vaccine. So you can see here, due for HPV vaccine. First of all, you need to have the vaccine available. You need to have that patient's HPV vaccination history. The staff needs to understand what the HPV immunization schedule is, and the practice needs to agree upon what that schedule is. And then you need to recognize that HPV vaccine is actually due for that patient. And that's where prompts or standing orders can come in to play and help support your vaccination and make sure that vaccine gets delivered. So as I said, a missed opportunity is when a patient is eligible for the vaccine and it's not given. In a large national health claims database study, 96% of unvaccinated girls had at least one missed opportunity for HPV vaccine between 2006 and 2012. And as you might expect, these occur more often at acute care visits where we're less likely to think about giving HPV vaccine. And this graph here illustrates the impact of eliminating missed opportunities by age 13 years in girls who were born in 2000. So the actual percentage of females who receive one dose of HPV vaccine is 47%. If we had eliminated those missed opportunities, the immunization rate would be 91%. So from doing your AFIX visits, you know from your visit questionnaire, you have a list of strategies there to reduce missed opportunities. I'm not going to go through all of these. I'm going to just focus on some that we work with. And the first I'm going to focus on is standing orders. So what are standing orders? The definition of standing orders is standing orders authorize nurses, pharmacists, and other healthcare professionals, where allowed by state law, to assess a client's immunization status and administer vaccinations according to a protocol approved by an institution, physician, or other authorized practitioner. Basically, a standing orders protocol allows assessment and vaccination without the need for examination or direct order from the attending provider at the time of the interaction. So we went back and looked at the research on standing orders. So between 1980 and 1997, there was 11 studies of the use of standing orders for immunizations or vaccinations. And there was a mean increase of 20% of vaccination coverage when standing orders were in place. Looking more recently, from 1997 to 2009, there have been an additional 29 studies. Vaccination rates increased 17% with standing orders, but that rate in children was 28%. So basically, studies have found that standing orders are effective in multiple clinic settings among various providers and populations. So here is a sample standing orders protocol for HPV. You can download this at the website below, www.immunize.org. And then basically the outline for standing order protocol is nurse or some other staff member reviews the medical chart for every adolescent visit to determine whether that patient is eligible to receive the HPV vaccine. The nurse would then give the HPVIS to parent or guardian, answer any question, and obtain consent. The nurse can administer the HPV vaccine and then document the vaccine given in the chart. So who can administer vaccine under standing order? Really, each state regulates the practice of medicine, nursing, and pharmacy. So you should contact your state immunization program or the state board of nursing to verify who can give vaccines and who can authorize a standing order. So usually approved by an institution, physician, or authorized practitioner. So in summary, standing orders can be very effective to increase immunization rates. There are some challenges involved in implementing, so there can be some state or facility regulations that are prohibitive. There can be some provider resistance. Sometimes providers are reluctant to give immunizations without examining the patient. And there may be a lack of nurse self-efficacy. We have heard that some nurses are uncomfortable with communicating with patients, particularly around the HPV vaccine. So it really relies on a strong practice teamwork and openness to change to implement standing orders. So again, if we look back at this missed opportunities for HPV vaccine, we see the opportunity for prompts as a way of remembering to give the vaccine. So provider prompts are patient or encounter-specific information provided verbally, on paper, or on a computer screen, which is designed or intended to prompt a health professional to recall information. So why do we need provider prompts? Well, as Clement J. McDonald noted in its 1976 New England Journal of Medicine article, the amount of data presented to the physician per unit time is more than he can process without error. So patient visits are often brief, and the immunization schedule is becoming increasingly complex. So with that in mind, provider prompts can be a really useful tool or strategy to improve your HPV immunization rates. So this is a process for provider prompts. Staff would review the medical chart for every adolescent visit to determine HPV eligibility. The staff would place the prompt in the agreed upon location. Staff would then document placement of that prompt in the patient chart. And then the person who gives vaccines documents status of HPV vaccine, whether it was given, declined, etc. So there are several different kinds of prompts. There are paper prompts, electronic prompts, and verbal prompts, among others. And I'll go over each in a little bit more detail on what these might be. So I'll start with paper prompts. So it could be a prompt in the chart. So some sites will use a colorful sticker or a post-it to remind physicians to remove vaccines or to identify patients who are eligible for vaccine. There could be a stamp in the preventative services due. Or you could make changes to the physical environment. So some sites will raise a certain color flag outside the exam room. There may be more generic prompts, such as posters or materials around HPV vaccine to try to remind staff, or it could be patient-specific, such as placing the VIS information sheet in the exam room to prompt the provider that the patient is due for the vaccine. So it can be aimed at the physician or the nurse. So basically you want to target whoever is providing the immunization. And we have found that they're most effective if they require a response. So this could be a simple check mark or some way that the immunization provider needs to acknowledge that they saw the prompt. So this is an example of a paper prompt from one of our sites. So this is kind of a standard rooming assessment. You can see here we have the vaccines that are due. Electronic prompts are typically, there can be two kinds. There can be like purely electronic, so the computer does all the work, or they can be in the computer but does require some human interaction. So if they're completely electronic, basically the EHR uses decision-making support to determine which vaccines are due for a patient and then may fire a prompt or an alert to let the provider know which vaccines that patient's due. These are convenient because they're based on information that's already in the EHR. So the prompt could be something such as a pop-up screen, a flag in the header, or on the side of the screen. They tell providers which immunizations are due, and in some systems, these can be linked to the ability to order the vaccine. The thing with these prompts are rarely a hard stop, so often providers may see these but just breeze right past them. So again, as we said with the paper prompts, these work better if it does require some action by the provider, so you know that they have seen the prompt. There are also electronic prompts that can be placed manually by staff in the EHR. So these can be something like post-its or notes or something like that that show up in the EHR for specific visits. Those are obviously require more resources of staff time. So here is an example of an EHR prompt for an 11-year-old male. So it's showing you which vaccines and the date they're due in the Health Maintenance tab. And then below you see a pop-up box for best practice advisory, again recommending the vaccines that are due. Some barriers to electronic prompts. The coordination between nurses and providers. This is particularly related to prompts that staff have to enter into the EMR. If you do that, you need to also remove the prompt once it's complete. This is really important because if incorrect prompts are placed, it really results in providers ignoring them rather than responding to them. So it's important if a prompt is there that it be accurate. Often electronic prompts, you're addressing reminders while you're not with the patients. So with EHRs, often the documentation is completed after the patient is gone. These can be time consuming, especially if staff is placing a prompt. Often, depending on the EHR, there can be a lack of flexibility as far as where these can show up. So we often hear from practices that where the reminder or prompt shows up is not in a page that providers see during the visit, and they're not able to move them. And then often we hear that they're just not usable. There aren't enough options for practices. Things that are useful if you're using electronics is to really limit the number of reminders, because as we know, there's a lot that needs to happen during patient visits. Immunizations are just one of them, and so practices can often get into case of alert fatigue where they're doing reminders for too many things. So really limit the reminders. You want to integrate the reminder into the workflow and then have a feedback mechanism to fix concerns or to acknowledge that the prompt was there. I'll next just do a quick overview of verbal prompts. The most common verbal prompt that our sites report using is patient huddles, and that really just involves including the patient's immunization status in the pre-visit planning and reviewing it during the daily huddles. This is a great strategy. We've had many practices report this as being very successful. The only drawback to this, it's not as useful in capturing appointments that are scheduled the same day. Other verbal reminders could be throughout the day. So appointment specific, rooming staff might remind the provider the patient is due for a vaccine before they go into the room or something like that. So if a practice wants to implement prompts, there is some planning involved. So first you want to determine what type of reminder you want to do. And we often have sites really try different ones to identify what works best for their workflow, what works best for providers actually seeing and responding to it. So a site may need to try a few different types before they find what works for their situation. Before you implement them, you really want to map out the process of reminding from the determination of vaccine eligibility through giving the vaccine. So what are those steps? And we recommend doing a process map, and that's great for identifying kind of the current process and then where that prompt is going to fit in that process. And then you really want to pay particular attention to communication between providers and nurse and other staff, as that is crucial in the prompting process. So typically the education that's needed prior to prompts is education about the immunization schedule. It's really clear that everyone understands the dosing guidelines and the minimum gaps between doses. So it's useful to have a current vaccine schedule posted where all staff can see. It's important to understand the contraindications and precautions to HPV vaccine. So the only contraindication to the vaccine is life-threatening allergic reaction to HPV vaccine or to any component of the HPV vaccine. So true contraindications are relatively rare. Precautions are pregnant female or moderate to severe illness. And again, most acute visits, most illness does not really exclude patients from receiving the vaccine. I think often providers are reluctant to give the vaccine at acute visits, but really, particularly for mild acute visits, they can still receive the vaccine. And then all staff should be aware of and use a strong provider recommendation for the vaccine. So it really takes more than a prompt. So the prompt really should include the entire office. All providers should be in agreement about the schedule, the strength of recommendation, and what visit types you will vaccinate at, whether you will agree to vaccinate at acute visits. And the prompt must be accurate and clear. So as I said earlier, the data used to trigger the alert must be accurate, and the alert needs to be present at the right time to the right person. And again, as I said earlier, be aware of too many alerts, because that will really lead to alert fatigue, and their purpose will be lessened, or their impact will be lessened. So now I'm going to go over reminder recall. So this is a strategy to improve the quality of immunization services, and this is one of the strategies on the AFIX visit checklist. So the first thing I like to define is what really is the difference between a reminder and a recall when you're trying to get patients in for HPV vaccine. So a reminder is letting families know when the adolescents are due to get their next HPV vaccination so that they can make an appointment to come into the office for it. Recall is really contacting families or adolescents who are overdue for a dose of the HPV vaccine, and trying to get them to make an appointment to come back in for it. One of the biggest points of confusion we have with our practices is the difference between reminder recall versus appointment reminders. So often we have practice report that they're implementing reminder recall when they are really just doing a phone call to remind patients of an already scheduled appointment. So this isn't really a true reminder recall, because the patient already had an appointment to receive HPV vaccine. It's definitely a great office practice and great to reduce no-shows, but it's not really what we're defining when we are speaking about reminder recall. So with reminder recall, there are several methods by which you can message patients, either to remind or recall them. So the first is a phone call from the office. The pros of this is it's personalized. If you get through to the patient or parent, you can directly schedule the appointment at that time. The con is this can be time consuming. So depending on your patient size and the number of patients who need to be reminded or recalled, this can definitely take some time. You can also use auto dialer. The pro is that's it's inexpensive and doesn't take as much time. The con is phone numbers change. You don't know who received the message, and then the patient needs to call the office to schedule an appointment. You could use mail, so several practices might use a postcard or a letter. The pros of that is you know it was received, but it is expensive, and patients again need to contact the office to schedule an appointment. Several practices have tried using patient portals to message patients. This is a very inexpensive and not time-consuming method. You'll know if the message was received. Again, the con is patients need to contact the office to schedule an appointment, and then sometimes you don't know how frequently patients use their patient portal. And then last, there's text message. This is inexpensive. Research shows a good response rate to this, and patients can reply instantly to schedule. The con of this is you do need consent from the patient to send auto dialer messages. So a sample process for reminder recall is shown here. So practice would use their EMR, immunization information system or billing system to generate a list of patients who are overdue or due for the HPV vaccine. So really, to keep this manageable, you want to somehow limit your So yes, to keep your patient list manageable, you really want to define some criteria. So for example, you might limit it to patients who are turning 12 this month who have not yet received 1 dose of the HPV vaccine. So in that case, you would be recalling patients who are overdue to initiate the series. Or you could limit it to patients who have a birthday this month who are overdue for their 2nd dose of HPV vaccine. That way, it's a process you can do monthly. It's a manageable number of patients, and you have some kind of systematic way of going through it. So once you've identified your list of patients, you would then message the patient or family by whichever mode you've chosen, phone, mail, text, or other. The patient would make the appointment for HPV vaccination and then come in to get the vaccine, and it's documented in their chart. Common challenges with reminder recall. When using the phone, you often get a wrong number or disconnected phone number. So our suggestion is if you encounter this, you can follow up by sending a mailing. You can put an indication in the EMR or scheduling system so that if they do call for any reason, say for an acute visit, the appointment for HPV vaccine can be scheduled. And try to update their phone number, and then begin routinely gathering cell phone numbers. Often you will make contact with the family, but they don't make an appointment. So again, what you would do is make a notation in the patient's record and or billing system to try to schedule a vaccine if the family calls the practice for any reason, or if the patient is in for a different type of visit. So takeaway points for reminder recall. It is very helpful, but it's not necessarily a perfect solution to improve HPV immunization rates. We'll say typical response rates are usually 10 to 30%. Practices need to use and identify that reminder recall method that best suits their needs. And the combination of reminder recall with minimizing missed opportunities to vaccinate when patients come into the office for any reason is probably more effective than just doing any one of these initiatives. So combining reminder recall with a prompting system, or combining reminding recall with standing orders is more effective than either alone. So finally, I'd like to wrap up with some stories from the field, and these are basically lessons learned from practices who participated in our NIPA Learning Collaborative, the lessons they learned, their experience, and any tricks that they found that were successful. Next, I want to talk about middlebury pediatric and adolescent medicine. This is a practice in Vermont, again in our first cohort that participated in the project, and they used a simpler prompting method. They just used Post-it notes. So we were fortunate that this site, they shared their results kind of twice with us. So when they shared, they said the key things that they found with success were everyone in the practice was passionate about this work. So what they did, their prompting process was on a daily basis. They had a patient coordinator associated with this practice. That patient coordinator would check all the patients to see if they were eligible for HPV vaccine. If they were, they would write out who was due on a Post-it note and put it on the nurse's computer. So that was done manually by the patient coordinator every day. So this did initially require quite a bit of work on her part, but as they went through this project and they saw the success that these prompts were having in reducing missed opportunities, they made checking immunization status part of the standard workflow for nurses, part of the pre-visit planning. So it became automated, was far less time resourceful, and the patient coordinator was able to step away from that work, and the nurses really took that over. In addition to these Post-it notes, they also brought in more educational materials around HPV vaccine, including some that were graphic. And we've heard from several sites that some of the more graphic ones can have an impact, and they report, especially for males, it can help convince them to get the vaccine. And they also sent out outreach letters for those, reminder letters for those who are due to start the series. What they identified as kind of key to their improvement in this work was staff education. So they trained all their staff in a strong provider recommendation. And they said that doing this and watching our training webinar for strong provider recommendation really changed people's perspective about the HPV vaccine and how they communicate with patients. So similar to what we saw with Martin's Point Pediatrics, this is a practice where communication was consistent from the time the patient walked in the door around HPV vaccine. What was wonderful about this practice, they just recently presented for our fourth cohort of the project. So we were able to see their data from when they started this project to now 3 years out. And what they reported is that this work, the work they did has been sustained. As I said, they were able to operationalize this prompting process, made it part of the nurse's pre-visit planning. Their rates continue to increase and have been sustained at a high rate of HPV series initiation and completion. And then last, I'm going to share work done by University of Southern Alabama Adolescent Medicine. This is a practice that used patient huddles, or daily huddles, as to do verbal prompts for the HPV vaccine. And I liked the strategy they shared for a few reasons I'll share. So one, they included immunizations into the pre-visit prep and to what was discussed in their daily huddles. So they developed a spreadsheet, the one shown here, that was populated by the nurse, which identified all patients and the vaccines that were due for that day. So during the patient huddles, the physician would review this and then signed the order for these vaccines. So while they did not have formal standing orders for HPV vaccine, using this process, they had kind of a standing orders light. So the vaccine was ordered prior to the MD seeing the patient, and they could receive the vaccine. In addition to using the verbal prompt in in the patient huddles, they also did an alert command in their EHR to further remind them of the work. So now I'd like to share some strategies that we heard from practices that implemented reminder recall that they found especially effective. So Schultz Pediatrics is a practice in Tennessee. They implemented a reminder recall system, which initially was not very successful. So they were frustrated with the return rate, we'll say, on their reminder recall, and they were telephoning patients as their messaging strategy. And what they discovered while doing that is that they found that adolescents weren't able to really come in during their clinic hours because they didn't want to miss school. So what they did is they developed a weekly HPV vaccinating clinic that ran from 4 to 5:30. So it was a clinic solely for HPV vaccine. Then what they did when they were calling patients to have them come in for the vaccine, they identified, all right, the clinic is on this day at these times. Are you able to come in? And they found they were able to fill their slots very quickly. This time was far more convenient for adolescents and their families, so they wouldn't have to miss work or school. and they had a much higher return on the work they were putting into their reminder recall. Similar to Schultz Pediatrics, Boulevard Center Pediatrics used a strategy where we talk about it being adolescent friendly. So kind of having off hours for adolescents is a great strategy for getting them to come in for your clinic. So they also implemented a reminder recall. They initially tried using their patient portal to message patients. They didn't find that was very effective for them, so they tried doing calls. And again, they were observing the similar issue that Schultz Pediatrics had observed, where patients, it just didn't work for them to come in during clinic hours. So they started a Saturday clinic for giving HPV vaccine. And again, they had a much higher rate of patients coming in to receive their the vaccine when they were able to come in on the weekend. And then they also used several of the tools available from Merck. So Merck has a texting system, so patients got an automatic text when the next dose was due, and they reported their patients like this. And then they used also a Merck magnet that they reported parents really enjoyed. And then finally, I'll share a strategy that the adolescent healthcare at University of Alabama, Birmingham used, and that was a postcard system. So what adolescent care at University of Alabama, Birmingham, they kind of had multiple strategies they used. So first, they had the nurse would offer the shot when they were rooming the patient. And again, they had the nurse use a strong provider recommendation. They had a particular disparity with males receiving the HPV vaccine. So they had brochures that specifically targeted males. And then they tried to have the nurse give the vaccine at the start of the visit via standing orders. And the physician only needed to discuss it with patients if the family or a patient had a concern about the vaccine. And then if the family declined the vaccine, the provider had them sign a declination form. And again, a form like this can really emphasize to parents how strongly the provider feels about the value of this vaccine. So where they used a postcard for the reminder recall is they did a reminder. So when a patient was in and received their first dose of a vaccine, the patient would fill out the postcard you see on the right here themselves. So they'd have the address, they'd fill it out and enter the date. And then this would be mailed to them as it came time for their next dose of HPV. Now, this was done at the time where we still had the 3-dose series for everyone, but it could be modified for any dosing schedule. So they found this was a great strategy for both engaging patients in the process of remembering to come back in and then actually getting them back in. And then finally, I'll talk about some of the strategies that clinics that implemented standing orders had to share with us about their learnings. So the first is from Pediatric Primary Care at the University of Vermont Medical Center, where they wanted to use their flu clinics as an opportunity to capture patients for HPV vaccine. So the team was really excited about implementing this because patients are coming in, they're mentally prepared to get a shot. Another one, they felt like offering the HPV would be an easy sell. However, when they brought this to their practice management, they were told they couldn't do it. So first, they didn't have standing orders for HPV vaccine. So without these standing orders, it wouldn't really fit into the flow of flu clinic because the nurse would have to open a new encounter and a new note specific for the HPV vaccine that the provider would then need to sign off on. But what happened, this site was so, they just really want to use this venue to capture patients. So basically, nurses just made the commitment that they were going to do that. They were going to make a new encounter for HPV vaccine. They would look up their immunization status, and they would get the doctor to sign off. So through kind of sheer will and persistence, they pushed it through. And they found that doing this, they had very high uptake by patients because they are already in there, mentally prepared to get the shot. And so getting another one was no big deal. The drawbacks of doing this was, when the flu clinic got busy, it was much harder to kind of tag on that HPV vaccine. But we did have several sites report using flu clinics as that opportunity, and really training nurses to look at when the patient is in to receive any vaccine, to look at what other vaccines they might be due for and to try to give those at the same time. I already talked some about the adolescent healthcare at the University of Alabama, Birmingham, who did have standing orders in place for HPV. But what they found is that when they started the project, these weren't really being acted upon. And the reason for it was that nurses really didn't feel confident or comfortable in talking to patients and parents about HPV vaccine. And so even though they had standing orders in place, they really weren't being used to the maximum effect. So as a key part of their work in increasing HPV rates and reducing missed opportunities, this site really engaged all their nurses, had them watch our Strong Provider Recommendation webinar, really train them on them, use some of the tools from the CDC about truths and myths for the vaccine, so that nurses began to feel more comfortable talking to parents about the vaccines, and they could use that Strong Provider Recommendation to offer the vaccine to families before the provider saw them. And by using the strategy, really educating staff on communication about the vaccine, their standing orders for HPV vaccine really became more effective. And then the final site I want to share is Fairfax County Health Department. This is located in Virginia, and we had 5 of their health department sites participate in our project. And so health departments are clearly different from community practices as far as what type of care they provide and how they provide it. But what they discovered, so they had immunization visits where folks would get their vaccines, but they realized that they weren't always looking, a patient might come in and ask for Tdap, the Tdap or meningococcal vaccine, or the vaccines that were required for school, and they would just give those. What they started to do was, instead of just giving those, they would look at what they were due for. If they were due for HPV vaccine, they would recommend they get that vaccine as well. So they would do what we call concurrent missed opportunities for HPV vaccine, so where the child is receiving another vaccine but doesn't get the HPV vaccine through that. But the other key thing they did, and this is a strategy we asked all sites to do it, is they started offering the vaccine at all visits. So all their visits are nurse visits, but they have travel clinics, pregnancy checks, lice checks, etc. So at those non-immunization visits, these county health departments started looking at immunization status and offering patients who are due the HPV vaccine a dose of the vaccine at those sites. To support this work, again, they had all staff get trained on a strong provider recommendation for HPV vaccine. They also developed kind of talking points for staff to work with patients. And then they supported this work with some other materials. So laminated guides about HPV vaccine. They got some more materials to post in the lobby in their exam room, some CDC posters. And then they started really documenting why someone refused the vaccine. So I think in sum, what we've learned from our multiple cohorts of doing this work is some key strategies to success are really engaging the whole practice. We find that consistency and communication about the vaccine to families and patients is really critical. And having it be consistent from the minute they walk in the door, that first encounter with reception, to the person who rooms them, to the provider, is really shows a united message and reinforces the value of the vaccine. And in addition, what we hear from practices who engage everyone is that staff really feels empowered by this responsibility in this work and are more engaged and enthusiastic. So the other thing we've already talked about is the communication. So offering the HPV in a presumptive manner using that strong provider recommendation, having it start at check-in. So say, oh, you know, Tommy here, he's 11, so he is due for 3 vaccines today. And then really training staff about a strong provider recommendation and about the HPV vaccine so that they feel comfortable talking with patients and family about the vaccine and providing education as needed. So we see kind of a shifting in many of these practices from the provider needing to do the education and communication, shifting it away from them to other staff, which really both reinforces the message but lessens the need for the provider to do that. So really, the provider is only communicating with patients about the vaccines who are reluctant or who are going to decline the vaccine, and that many patients, by the time they receive the provider, have already consented to the vaccine. The other thing we learned is be persistent. So we hear, you know, keep offering the vaccine even if the patient previously declined it. You never know what has changed since their last visit. So maybe they know someone who was diagnosed with an HPV-related cancer. Maybe they saw some compelling ad. Maybe, you know, there was communication between peers that really convinced them. But keep offering the vaccine. And then really experiment with different methods to find out what works in your system. So sometimes when we have practices share what they're doing, there's what I call some QI envy. And this kind of gets to our last point, where all improvement is local. So one size does not fit all. So what works in one practice may not necessarily work as well or work the same in a different setting. So really, practices need to modify strategies to fit with their culture and structure. So, you know, I talked about the practice that had a patient coordinator who was able to initially take on this excess work to identify which patients were overdue. Well, not all practices have the luxury of having a patient coordinator, but they can look within their staff and who has time and who has the ability to do this task. So really make things fit with the system you have in place. And, you know, we talk about the provider prompts. There's so many different ways to prompt. Really, you just need to find out what is most effective in your system. And you want to make sure that the strategy that you're picking is addressing kind of the reason for these missed opportunities. So is the reason that kids aren't getting the vaccine because providers are forgetting to offer it? Or is it because patients aren't coming in for visits or don't know they need to come in for visits? So depending on what that reason is really going to help guide the strategy you choose to reduce your missed opportunities. So in closing, I'd really like to thank the faculty from our NIPA project, Dr. Paul Darden at the Oklahoma University Health Sciences Center, Dr. Sharon Humiston from Children's Mercy Hospital, Rebecca Perkins from Boston Medical Center, and Dr. Cynthia Rand from the University of Rochester School of Medicine and Dentistry. And I'd really like to thank all the sites that have participated in the NIPA HPV Learning Collaborative and the lessons they have learned and shared with us so that we can share with others. So thank you for listening. We do have 2 other webinars in this series. We have a Quality Improvement 101, and we have a webinar, Tools and Tips for Working with Clinical Practices. Thank you.